My topic is lymphatic malformations, which were previously known as lymphangiomas. My name is Dr. Khwaja Khalid Shoaib, and I am President-elect Pakistan Oculoplastic Association. So, lymphatic malformations are low-flow orbital vascular lesions, and they result from changes in the embryonic pluripotent cells that forms vascular tissues. So, these are congenital malformations and may involve conjunctiva, lid, oropharynx, or sinuses. These can be macrocystic, the cysts more than 2 centimeter, microcystic or mixed macrocystic and microcystic. Usually present in the first or second decade of life and cannot be decompressed, do not distend with Valsalva maneuver, and may enlarge during respiratory tract infections and may cause sudden proptosis due to spontaneously intralesional hemorrhage, which is called chocolate cyst. So this is corneal ulceration and proptosis resulting from vascular malformation. Natural history is variable. Some are localized and progress slowly, while others may diffusely infiltrate orbital structures and enlarge enormously. MRI may show pathognomic features, which include multiple grape-like cystic lesions with fluid layering of serum and red blood cells. Combined lymphatic and venous malformations may be encountered, which possess a significant venous flow component and have clinical characteristics that overlap with venous malformations. Histologically, the pure lymphatic malformations have serum-filled channels lined by flat endothelial cells that have immunostaining patterns consistent with the lymphatic capillaries. Scattered follicles of lymphoid tissue are found in the interstitium. They have infiltrative pattern and are not capsulated. So these are the some of the cases which I encountered in the last 20 years. So the management is challenging because of their infiltrative nature and because of the risk of significant hemorrhage that can occur during surgery and because the recurrences are common. Non-contiguous intracranial vascular malformations occur in 25% of the patients with orbital lymphatic malformations. There is low rate of spontaneous hemorrhage and they are not treated prophylactically. The treatment may consist of observation only for lesions that are asymptomatic and not embryogenic. But if the lesions are large or producing cosmetic disfigurement, then debulking of the lesion can be done or intralesional sclerosing agents can be injected percutaneously or intraoperatively. So this was a lymphatic malformation and this is a pre-operation and this is after debulking of the lymphatic malformations. Has become cosmetically acceptable now. Sclerosing agents, different agents are used including the thrombosing agents and embolizing agents, but bleomycin is the most commonly used agent. Acute hemorrhage in the lymphatic malformation can be complicated by optic neuropathy or corneal ulceration. So we can do an ultrasound guided aspiration of blood through a hollow bore needle, or we can deal with open surgical exfoliation. So this was the patient who presented with proptosis, chemosis, redness, lid edema, and injection bleomycin was given, and this resulted in gradual recovery of the patient, and you can see the edema has gradually decreased along with the chemosis of the conjunctiva. So this is the pre-injection photograph and this is after the complete recovery. So thank you very much for a very patient listening.